All right, welcome to the audio learner. This is going to be video number 3. The first one was the first part of perio. Second one was the first part of care with special needs patients. This third one is going to be the second video for the care with special needs patients, where we will be talking about chronic kidney diseases, alcoholism and drug addiction, and leukemia. So we're going to stick to those three for today. Let's get right on to it with the verbiage. All right. So we are going to be talking about chronic kidney diseases and the management of each of the 5 stages. So we're going to say, what is it? We're going to talk about common treatment modalities and medications, drug interactions, systemic implications, and adverse effects, and clinical signs and symptoms. Also, the management of special precautions, barriers, dental services, do's and don'ts, and then if there is any consultation. So, what is chronic kidney disease? Well, it's when waste and extra fluid build up as kidney function deteriorates, and anemia and hypertension frequently develop. Chronic renal failure, um, also known as CKD. Uh, Chronic renal failure, also known as chronic kidney diseases, results in a progressive disease of the kidneys, capacity to filter waste products, concentrate urine, and storage of electrolytes. So you have the glomerulus, the collecting tubules, and that's for a normal kidney disease. Kidneys have scar tissue, damaged glomerulus, and damaged tubules. Okay, so stage 1 through 5. So, the most accurate means of measuring renal function is GFR, glomerular filtration rate. The GFR tells you how well the kidneys are filtering. So, stage 1 renal damage is stage 1 renal damage with normal GFR of greater at or greater than 90 milliliters per minute. Renal damage may occur before a reduction in GFR. So, stage 1 is at or greater than 90 milliliters per minute. Stage 2 is renal damage with mild decrease in GFR. So that is between 60 to 89 milliliters per minute. That's stage 2. Stage 1, at or greater than 90 milliliters. Stage 2, between 60 to 89 milliliters. Stage 3 is moderate decrease in GFR. That's 30 to 59 milliliters per minute. Anemia and bone metabolism disorders are more common for people at this stage. And chronic kidney disease is defined by a GFR of less than 60. So, stage 4 is severe. That is a GFR of 15 to 29 milliliters per minute. Patient is unable to maintain essential life functions unless direct dialysis is initiated. And then stage 5, that sounds like terminal, basically less than 15 milliliters per minute, 75% or more, approximately 2 million nephrons. Approximately 2 million nephrons have lost function. So let's do it real quick. Stage 1, at or greater than 90 milliliters per minute. Stage 2, between 60 to 89 milliliters per minute. Stage 3, between 30 and 59 milliliters per minute. Stage 4 is, no, stage 3, excuse me, stage 3 is between 30 and 59 milliliters per minute. And this stage is, classified as chronic kidney disease. So once you hit stage 3, you have chronic kidney disease because it is less than 60, GFR. Anything above 60 GFR is stage 2 or stage 1. Okay, so that's stage 1, 2, 3, 4, 5. Stage 4, between 15 to 29, and stage 15 is less than 15. Okay, stage 5, less than 15. Common treatment modalities and commonly used medications. So, preventative treatment to delay or avoid end-stage renal disease includes the pharmacologic use of angiotensin converting enzyme inhibitors, so ACE inhibitors, and angiotensin receptor blockers. So ACE and ACE and ARBs. When the kidney stop functioning, dialysis or solid organ kidney transplant is the treatment of method of cleaning and filtering waste and toxins from blood when the kidney loses their function in end-stage renal disease. In hemodialysis, the patient's blood is cleansed with a specific filter. Peritoneal dialysis filters the blood of a person living with ESRD, end-stage renal failure. So peritoneal dialysis um, sounds like the worst type of dialysis. Uh, but the treatment modality uses the person's own peritoneal lining to filter the blood. So, no dialysis treatment modality is considered medically superior to the other. However, the success of treatment is complex and often is geared towards compliance, convenience to the patient, and acceptable clinical outcomes obtained by the treatment modality. So, the drugs and reactions. So, ACE uh, inhibitors are called, they have the prill at the end. So angiotensin converting enzymes such as benazepril. The reactions are headaches, dizziness, drowsiness, dry coughs, hacking, non-productive cough, potentially interfere with longer dental procedures if the patient has that side effects. That's the ACE inhibitor, prill, ACE prill. Then you have angiotensin receptor blockers, ARBs, such as irbesartan, Avapro. So that's the generic name. The reaction for ARBs is adverse reactive dizziness, orthostatic hypotension, diabetic neuropathy. Caution with sudden changes of positioning for ARBs. I think I would also be cautious if they even have ACE inhibitors, just because of the. Also, they also have orthostatic hypotension. Okay, clinical signs and symptoms of chronic kidney diseases. So they can have cardiovascular disease, gastrointestinal, neuromuscular, dermatologic, bleeding problems, immunologic, metabolic, endocrine. So just a wide array of problems. So not good. Hypertension, congestive heart failure. They can have anorexia or loss of appetite. They can have fatigue, weakness. They can have itchiness, bruising. They can have bleeding, anemia. They can have infections, bacterial, viral. So not good, not good, not good. None of these. Excessive urination and thirst and elevated lipids. Some people miss the yearly warning and signs and symptoms, and a lot of people aren't diagnosed until it is irreversible bilateral kidney damage. Sounds horrible. Um, let's see here. Um, looks like we kind of just spoke about these clinical manifestations caused by chronic renal disease, also known as chronic kidney disease. Um, so let's see. Clinical oral signs. Again, xerostomia, bacterial, viral, fungal infections, erosions of lingual surfaces might be because of the vomiting or gastrointestinal reflux, white patches of uremic frost on their head, petechiae, the little tiny red dots all over their body or in the mouth, and increased calculus formation. Um, yeah, bunch of them. Management and special precautions in the dental office. So you need to identify, then you need to assess the risk, and then there might be antibiotics. So high risk groups are people with diabetes and hypertension, or individual with signs of kidney diseases. You got to know their GFR rate, the stage of the chronic kidney disease, and the extent of the albuminuria. Okay. Chronic kidney disease stages 1 through 3 generally do not require antibiotics, additional antibiotics. But anything above stage 3, you need to consult with the physician for the need of antibiotics. So if they have stage 1, 2, or 3, you generally do not require additional antibiotics. They may already be taking them, but stage 3, you need to and above consult with physician. So there may be excessive bleeding with kidney disease. You need to obtain their platelet count. There might be hypertension is common in kidney disease. You need to monitor their blood pressure, and you need to see their capacity to tolerate care. So if a GFR is less than 50, elective dental care should be delayed until consultation is obtained by their physician. So a lot of barriers: cultural, psychological, social. So there's shortage of multidisciplinary care team, lack of insurance coverage, depression, anxiety, passive attitude towards self-management, lack of knowledge and awareness of kidney disease, and insufficient patient-physician communication. So the do's and don'ts of chronic kidney disease. On the day of appointment, avoid dental care on the day of hemodialysis, especially within the first 6 hours afterward. It's best to treat people with CKD 1 day after their hemodialysis. If a patient is on antihypertensive medication, assist the patient to regain equilibrium in an upright position before exiting the dental chair, so go slow. Um, the drug dosages of metabolized by the kidney, adjust dosage of drugs metabolized by the kidney when GFR is less than 50. Avoid nephrotic toxic drugs. Consider antimicrobial prophylaxis if abscess is present. Okay, OHI. So those were don't do's. More do's, dental do's. OHI, xylitol chewing gum. Recommend anti-plaque measures, chlorhexidine or triclosan rinses. Triclosan, okay. Recare interval, frequent professional prophylaxis and recare appointment. Now the don'ts. So what you don't do: no invasive procedures, long appointments if disease is poorly controlled, especially if it's stage 3 or higher. No long-term use of NSAIDs in kidney disease. No narcotics in kidney disease because these drugs cause prolonged sedation and respiratory depression. Blood pressure taking. Do not use dialysis access arm with the AV shunt for blood pressure measurements. So if you're taking their blood pressure, careful where they have the dialysis thingy-bobber. Consultation and referrals. Patient with diabetes and hypertension presents other known risk factors. Patient with CKD stage 4 or higher, consult with physician. GFR less than 50, consultation is needed before any hygiene treatment. So GFR less than 50, if we go back, GFR less than 50 is around stage 3, because stage 3 is between 30 to 59 milliliters per minute. But it says here that you are classified as chronic if it's less than 60. Okay, going back. Let's see. So where were we? So a patient with chronic kidney disease above stage 3, you need to consult with the physician. And that was chronic kidney diseases. Great. Now moving on to alcoholism and drug addiction. So common substances: weed, cocaine, alcohol, opioids, meth, and barbiturates. Alcohol, we know what that causes: drowsiness, impaired coordination, irritability. Cannabis, euphoria, relaxation, slowed reaction time. Opioids, lethargy, meiosis, which is small pupils, shallow respirations, hypotension. Opioids are heroin. Amphetamines, meth, ice crystal. Euphoria, restlessness, anorexia, seizures, talkativeness, tachycardia, agitation, confusion. Cocaine, agitation, anxiety, hyperthermia, seizures, chest pain, tachycardia. And barbiturates, slurred speech, such as barbiturates or benzo, slurred speech, lethargy, ataxia, nystagmus, rapid eyeball movement, pulmonary edema. Common methods of treatment: counseling, treatment facilities, detoxing plans, supporting groups, drug alcohol-free clubs, meetups, medical management, and pharmacotherapy. Medical management is to lessen the withdrawal symptoms. Pharmacotherapy, treatment of disease with medications. So for alcohol, there are 3 drugs approved for alcohol dependence: disulfiram, naltrexone, acamprosate. For opioids, it's naloxone or Narcan, which can be used to reverse the effects of opioids. Amphetamines are antidepressants, mild stimulants, antipsychotics. And barbiturates are gradual reduction of abused drug or similar drug. Looks like there isn't any for cocaine. Drug interactions. So cocaine, just stop. Drug interactions. Systemic implications that affect patients who abuse cocaine and methamphetamines are at greater risk for cardiac arrhythmias, myocardial infarctions, and stroke. Make sure to monitor blood pressure. Do not administer anesthesia with epinephrine on people who use cocaine or meth. Avoid epinephrine for at least 24 hours after the last time they used it. Patients with substance use should rarely be prescribed addictive substances. Alcohol may exacerbate the effects of other drugs. Signs and symptoms of alcohol: gingival bleeding, denosis, which are big glands on the cheeks, um, hairy tongue, and spider angioma on the nose. So the sialadenosis are bilaterally enlarged parotid glands. Petechiae, found spots, round spots on the skin. You can have angular cheilitis, candida, hemostasis, no blood flow, and splenomegaly, which is enlargement of the spleen. Also malnourishment. Symptoms: cannabis, chronic bronchitis, xerostomia, dry mouth, leukoplakia, squamous metaplasia, and chronic oral inflammation or cannabis stomatitis or candida. Now for opioids, xerostomia, bruxism, clenching, periodontitis, poor oral hygiene, caries, and opioids may mask dental pain. Oral signs and symptoms of amphetamines: xerostomia, neglect, poor oral hygiene, trismus, which is jaw clenching, bruxism, high intake of refined carbohydrates, direct acidity of the drug, increased acidity from gastrointestinal regurgitation, bulimia or vomiting. All of the above can lead to exacerbated caries and periodontal disease. Okay, oral signs and symptoms of cocaine: bruxism, ulcerations, erythema, and also palatal perforations. Um, so precautions in the dental office for alcohol: increased risk of bleeding. Cocaine, avoid use of epinephrines. Cannabis, anesthetics with epinephrine can cause chronic tachycardia. Opioids, do not prescribe opiates, analgesics to opiate abusers. Um, there are a lot of social and psychological barriers that we know of. People may be hesitant. People are just functional and act like they don't have issues. They may feel ashamed. They should be encouraged to seek treatment. They need to be, if you see someone experiencing substance abuse, refer them to physicians, rehabilitation facilities, conduction of services. So for alcohol, the patient who has abuse problems with alcohol, do brief discussions, talk about screening, brief interventions, referral treatment. Method of exploring alcohol abuse: it involves identifying behavioral signs for methamphetamines. The patient on the methamphetamine while you're on it, do not treat the patient if they're high on meth. Dental treatment should not occur until at least 24 hours of the last time they hit the meth. Cannabis: there may be harmful association between marijuana and ischemic heart disease of cardiac failure. Dental treatment should be postponed until patient is not high. Cocaine: patients should not receive anesthetic if they're on cocaine for at least 6 hours after the last time they did cocaine. Opioids, naloxone can be used as an overdose. Do not treat patients while they are under the influence. Perfect. Last one is leukemia. What is leukemia? Cancer of the white blood cells that affect circulating blood and bone marrow. Involves exponential proliferation of clonal myeloid or lymphoid cells. Cause is unknown for leukemia. So a normal blood cell has neutrophils and red blood cells and monocytes and platelets. Leukemia cells, there's just a bunch of abnormal white blood cells. So cancer of the white blood cells that affects, okay. So there's acute leukemia, rapidly progressive, accumulation of immature non-functional white blood cells in the marrow and blood. Two types of acute leukemia. There is AML, acute myelogenous leukemia, and there's ALL, acute lymphocytic leukemia. So AML is accumulation of immature white blood cells in the bone marrow. ALL is uncontrolled immature lymphoid cells in the bone marrow. Okay, chronic leukemia is a slower onset. There's CML and CL, chronic myelogenous leukemia, a neoplasm of mature myeloid white blood cells, and CLL, chronic lymphocytic leukemia, a neoplasm of mature clonal CD5 B cells. Okay, so AML and ALL. AML is a disease of adults, and incidence increases with age and may rise rapidly after the age of 50. Environmental factors such as tobacco, benzene products appear to be a risk factor. ALL typically occurs in children. So ALL is the acute lymphocytic leukemia, which usually occurs in children. Environmental infections and genetic factors are all likely causes. This disease, the ALL, is 18 to 20-fold more common in patients with Down syndrome. Hey, that reminds me of my cousin. Rest in peace, Bethany. I miss you. Um, about 5% of children, 25% of adults with AL have cytogenetics showing Philadelphia chromosome, a shortened chromosome 22. Interesting. CML occurs in people who are about 64 years old. And then CLL is the most common type of leukemia in adults. So CLL is chronic lymphocytic leukemia. That's the most common one in adults. And usually the median age of diagnosis is 71 years old. More common in men than women. However, survival rates are higher than women. CLL is rare in Asia and in children throughout the world. So acute leukemia, the signs of leukemia, acute leukemia are xerostomia, dysphagia, loss of taste, mucositis, trismus, hearing loss. Signs and symptoms of chronic leukemia are the same things like xerostomia. However, they have salivary gland dysfunction, continual fungal infections for chronic leukemia. So the CLs have fungal infections and salivary dysfunction, rampant caries, muscle fibrosis, TMD, osteoradionecrosis. That sounds pretty bad. So it seems like chronic is worse than acute for sure. Treatments for leukemia, chemotherapy um, to reduce the proliferated blast cells. Patients with leukemia will have 100 times more blast cells than patients without leukemia. Patients will go through chemotherapy and consists of 3 phases. If the patient relapses, then they need bone transplant. I'm thinking of marrow. Okay, drug interactions, xerostomia, nausea, fatigue. Okay, oral manifestations of acute leukemia, gingival enlargement, atypical ulcerations, recurrent infection, chronic leukemia, less likely to demonstrate oral manifestations compared with acute, but they have general lymphadenopathy, pallor, oral soft tissue infections may become evident as develop hypoglobulinemia. Okay, kind of all over the place with this one. Hard to put into very straightforward terms. Let's see. Patient with fungal, viral, or bacteria related chemotherapy induced immunosuppression, do not proceed with dental care. It says bleeding related to chemotherapy, dental hygiene should be delayed until the patient has a platelet count of greater than 50,000 or a blood transfusion. Okay, let's see. How should services collaborate with oncology team to assess immune status? Meticulous oral care should be stressed. High risk of active leukemia patients, thrombocytopenia, and neutropenia increases the chances of getting blood clot and susceptibility of infections. Okay, so this was not as straightforward as I liked, but looks like we need to make sure we know what a good platelet count is of at least 50,000. Greater than 50,000 for dental hygiene treatment. Do not proceed with care if they have fungal, viral, bacterial, chemotherapy-induced immunosuppression. All right, so CLL, CML, AML, ALL. So acute myelogenous leukemia, and chronic myelogenous leukemia, and so that's, and then CLL, ALL is acute chronic lymphocytic leukemia. So just know all is children. There we go. Seems like that's what we need to make sure we know mostly. Thank you.